I'm Dr. Shah, DRN PDT Critical Care Medicine. And today the topic of presentation is 2021 ACC-AHA Guideline for the Evaluation and Diagnosis of Myocardial Infarction. A report of the American College of Cardiology and American Heart Association Joint Committee on Clinical Practice Guideline. As the preamble is, since 1980, the American College of Cardiology as well as the American Heart Association, they have translated scientific evidence into clinical practice guidelines with recommendations to improve cardiovascular health. The intended use is clinical practice guidelines provide recommendations applicable to patients with or at risk of developing cardiovascular disease. Management in accordance with guideline recommendations is effective only when followed by both practitioners as well as patients. The methodology suggests that the clinical practice guidelines continuously reviews, updates and modifies guideline methodology on the basis of published standards from organizations. Then there is selection of writing committee members, relationships with industry and other entities, evidence review and evidence review committees, and as well as the guideline directed management and health. This chart shows the class of recommendation and level of evidence to clinical strategies, interventions, treatments or diagnostic testing in patient care. It has been updated at May 2019. Class 1 is strong recommendation, Class 2A is moderate, Class 2B is weak recommendation, Class 3 is divided into two parts, either no benefit and harm. And level of quality of evidence is level A, level BR that is randomized, level BNR that is non-randomized, and level CLD is limited data, and level CEO is expert opinion. Chest pain remains a diagnostic challenge in the emergency department and outpatient setting, and it requires thorough clinical evaluation. Of all emergency patients with chest pain, only 5.1% will have an acute coronary syndrome, and more than half will ultimately be found to have a non-cardiac cause. This left-sided picture shows the probability of ischemia from high to low depending on the clinical presentation of the patients. This is a schematic diagram of coronary heart circulation. As per the initial evaluation is for history. The main branches are from aorta. The main branches are left coronary and right coronary artery. Left coronary artery is further divided into main two branches: left anterior descending, which gives diagonal branches as well as two branches to anterior septum and anterior wall of the left ventricle. And other branch of left main coronary artery is left circumflex, which gives circulation to lateral wall of the left ventricle. When the right coronary artery is concerned, it gives branches, nodal branches to SA node and AV node, as well as it supplies most of the right ventricle part. As per the initial evaluation is
just go back to the previous slide. So, which artery supplies the inferior wall? Suppose you have written anterior wall, septal wall, lateral wall, no mention about inferior wall, no mention about posterior wall. So, any guess which branch will supply inferior wall and which branch will supply posterior wall?
Sir, inferior wall is also supplied by the left anterior descending and left circumflex.
Inferior wall is mostly supplied by right coronary.
See, naturally, if you remember, what forms the inferior wall of the heart? It is anatomically called, it was sampled the whole way. Inferior wall is formed by which chamber?
Right.
So, inferior wall is by right and left circumflex is posterior wall.
The other important clinical implication of knowing this is that when you have complete heart blocks and arrhythmias, they are more likely to be associated with what sort of problem? Which territory? Diagram में देखो, arrhythmias क्या होगा, heart blocks क्या होगा?
AV node, SA node artery.
So the right coronary artery, which means it will be most likely to be associated with inferior wall.
Go ahead.
As per the initial evaluation, the recommendation for history suggests that in patients with chest pain, a focused history that includes characteristics and duration of symptoms relative to presentation, as well as associated features and cardiovascular risk factor assessment should be obtained. The different chest pains, according to their characteristics and corresponding causes, can be evaluated as per nature. Anginal symptoms are perceived as retrosternal chest discomfort, like pain, discomfort, heaviness, tightness, pressure, constriction, and squeezing. Whereas the sharp chest pain that increases with inspiration and lying supine is unlikely related to ischemic heart disease, because these symptoms usually occur with acute pericarditis. As per the onset and duration are concerned, anginal symptoms gradually build in intensity over a few minutes. Sudden onset of ripping chest pain with radiation to the upper or lower back is unlikely to be anginal and is suspicious of an acute aortic syndrome. Fleeting chest pain of few seconds duration is unlikely to be related to an ischemic heart disease. Also, the location and radiation of the pain and severity of the pain is concerned. Ripping chest pain, as patient can tell you, means the worst chest pain of my life, especially when sudden in onset and occurring in a hypertensive patient with a known bicuspid aortic valve or aortic dilation, is suspicious of an acute aortic syndrome like aortic dissection. As per the precipitating factors are concerned, physical exercise or emotional stress are common triggers for anginal symptoms. Occurrence at rest or with minimal exertion associated with anginal symptoms usually indicates acute coronary syndrome. Positional chest pain is usually non-ischemic, it can be musculoskeletal involved. Relieving factors as concerned, relief with nitroglycerin is not necessarily diagnostic of myocardial ischemia and it should not be used as a diagnostic criteria. Associated symptoms that are associated with myocardial ischemia that can include but not limited to dyspnea, palpitations, diaphoresis, lightheadedness, pre-syncope or syncope, upper abdominal pain or heartburn unrelated to meals, nausea or vomiting. Symptoms on the left or right side of the chest, stabbing, sharp pain or discomfort in the throat or abdomen may occur in patients with diabetes, women and elderly patients. So the recommendation in this scenario is angina pectoris is perceived as a retrosternal chest discomfort that builds gradually in intensity over several minutes, is usually precipitated by stress, physical or emotional, or occurring at rest, with characteristic radiation to left arm, neck, jaw, and its associated symptoms include dyspnea, nausea, and lightheadedness. When actively treated or spontaneously resolving, it dissipates over a few minutes. Relief with nitroglycerin is not necessarily diagnostic of myocardial ischemia and it should not be used as a diagnostic criteria, especially because other entities demonstrate comparable response, like in case of esophageal spasms. Associated symptoms such as shortness of breath, nausea or vomiting, lightheadedness, confusion, pre-syncope or syncope, or vague abdominal symptoms are more frequent among patients with diabetes, women and elderly. So, a detailed assessment of cardiovascular risk factors, review of systems, past medical history, family and social history should complement the assessment of presenting symptoms. In case of women, the PROMISE trial is prospective multicenter imaging study for evaluation of chest pain. It looked at 6 differences in the presentation, risk factors, demographics, non-invasive test reference. It showed that women commonly presented with chest pain symptoms similar to men, but there are greater prevalence of other symptoms like palpitations, jaw and neck pain, and as well as back pain. In older patients, like patients more than 75 years of age, they may have symptoms of shortness of breath, syncope, mental impairment, abdominal pain, or they have experienced an unexplained fall. So the physician should have a heightened awareness to understand that these symptoms may be associated with acute coronary syndrome in addition to chest pain. Recommendation in case of diverse race and ethnicity patients. The diverse groups may present with chest pain, and also the cultural competency training of providers to address racial and ethnic disparities. It will help to improve diagnosis, treatment and outcome. So attention to race, ethnicity and socio-cultural differences should be considered. In physical examination.
No, ma'am, just to interrupt you. It's not just the reading of the slides that you are doing. It's what you have conceptualized about MI. We want to hear about that because it is a learning both ways. No?
Yes.
So only that you are reading the slides won't help you or us also.
As per the physical examination is concerned in acute coronary.
No, first of all, what do you understand by MI? What is the definition of MI?
Sir,
In any patient who comes to your emergency with acute chest pain, how does it qualify as an MI? When do you call them as having myocardial infarction?
Sir, a detailed history and clinical evaluation as well as the diagnostic testing is concerned.
No, what are the things that you will look for before telling that this patient is having an MI? You understand?
Yes. Sir, a detailed history of the type of chest pain or the symptoms the patient is presenting. I will be taking a detailed history of that patient. The type of chest pain as the patient is complaining of, it can be a retrosternal chest pain with that can increase with exertion or even at minimal activity as per the severity of the chest pain.
MI patients actually have pain during rest itself. So there is no point of qualifying an exertion as an additional stressor because these patients will be having pain itself in rest. Usually angina is never a pain. Angina is a discomfort. Okay, if you go to the initial coinage of the term angina, it was actually a discomfort in the throat, throat-like phenomenon. So angina here implies discomfort. So, all stabilization heart disease patients who have angina or equivalent symptoms, maybe shortness of breath or palpitation or whatsoever you have described, these are all brought on by exertion. Certain amount of exertion that is stereotyped and specific to that particular patient over the time course and relieved by rest or nitroglycerin as you mentioned. And this ischemic discomfort is usually described in form of a heaviness or like a pounding feeling in the chest or something like an elephant sitting, or as you can understand the Levine sign with the entire hand over the chest, means it's a diffuse nature of the discomfort that is described. That may be in the central chest or it may be in any of the areas of radiation. If it is not in the chest, in the areas of radiation like the jaw only or in the arm or itself in the back or upper abdomen, then it is atypical. So atypicality can be in terms of either your site or the duration. Usually the angina during your stable course, it's brought on over 2 to 5 minutes, and then also after taking solvitrate or taking rest is relieved over a certain similar duration. So it's not in seconds that you count it as angina. Okay, but in contrast, in case of acute myocardial infarction, the pain it's a definite pain. It's one of the worst severities of pain experienced by the patient, and in the scale of pain you can compare only gout and acute pancreatitis with acute myocardial infarction pain. So this pain is diffuse in nature, it's not pointed by one finger, and this pain is usually over the central chest, the left or the right precordium, with or without radiation in the arms, both arms, or either of the arms, or the back, or the jaw, or the upper abdomen. Okay, and accompanied by autonomic symptoms like sweating, vomiting, and all. So any severe pain can cause all these phenomena. Apart from this, there are certain changes in the ECG. There are certain changes in the cardiac biomarkers and also changes in your imaging modalities, echo, etc. that you do. So there is a definite definition of WHO definition of your MI. No? Revised, the latest revision has been in 2018. So Are you aware of it? 2018 definition of WHO definition of myocardial infarction, universal definition. Okay. No, universal definition of myocardial infarction here specifically distinguishes it from myocardial injury. So, after the advent of the cardiac troponins, their increased use over time, from 2007 onwards, people were confused of which patients to qualify as myocardial infarction. Because high sensitive cardiac troponins, as they become more and more sensitive, so with trivial myocardial injuries, they become positive. Even in certain conditions like chronic kidney disease and your pediatric conditions, etc., the markers became positive. So whether all marker positive patients will be classified as myocardial infarction was a big debate. Then, as per the scientific committees, they put up this definition of myocardial infarction to stratify those patients who are actually having this component of infarction. And by definition, it states that it should be a rise and fall of the cardiac biomarkers, that the cardiac troponin I or the T, whichever your system uses. This rise and fall is to indicate the acuteness rather than a stable course of cardiac troponin rise where there is no rise and fall. So chronic kidney disease can have a stable biomarker rise over time. So that will not qualify as an MI. So it should be a rise and fall along with any one of the usual markers of myocardial ischemia. In terms of symptoms, what you have described, all patients should have ECG changes, SCT changes in terms of either dynamicity, either elevation or depression, or appearance of new pathologic Q waves, or imaging modality showing either a loss of viable myocardium or a new wall motion abnormality which was not present on the previous occasion, or in the setting of a coronary intervention, be it a bypass surgery or a PCI that you are conducting. So, any one of them will qualify these patients as having MI. New onset availability is by definition one of the criteria for screening diagnosis. But, so you understand. So, in this way, you have to define MI. First, you have to define MI and then you can classify MI. So, classification is again type 1, type 2, type 3, I think you are aware. Type 1 is basically where the process is entirely atherothrombotic. And type 2 where there is a myocardial demand mismatch causing MI. Like a patient in the critical care area, most of you might have encountered patient is having tachyarrhythmia, or patient is having hypotension, or patient is having a coronary embolism, or a spontaneous coronary dissection as a cause of rare causes of myocardial infarction. All of them will come into the category of type 2 MI. And type 3 will be patients whom the blood biomarkers could not be sent before that patient died. Sudden cardiac death issues or ECG changes are there, but initial your prop came negative and then patient didn't have time for a subsequent sample to be sent. So then you have the type 4 MI where it's related to the PCI. PCI can again be ABC. So where you have a periprocedural infarct during the intervention itself, or stent thrombosis related infarct type B, and type C is restenosis related infarct, a left main restenosis causing infarct. And type 5 is in the setting of CABG. So this should be clear cut. And then based on type 1 MI, again you can re-stratify based on the ECG, ST elevation as STEMI and the non-ST elevation non-STEMI. So like that, the classification should go.
As per the physical examination of acute coronary syndrome, it can include diaphoresis, tachypnea, tachycardia, hypotension. On auscultation, there can be crackles, S3 rhythm, or any mitral regurgitation marker. Examination may be normal in case of uncomplicated patients.
So, what is the cause of a mitral regurgitation marker in the setting of acute MI?
Sir, in case of any atherothrombotic cause or any
now, why MR should appear? Why mitral regurgitation should appear?
So, in case of any atherothrombotic or any thrombotic complication.
Myocardial infarction is occur, but while MR should appear acutely. Absolutely. So papillary muscle dysfunction is the most common cause. Usually papillary muscle dysfunction, and uncommonly papillary muscle rupture or caudal rupture can occur. So this is one cause, important cause of mechanical complication related to acute MI.
In diagnostic testing, the ECG is central to the evaluation of stable angina in the office setting to ensure that acute coronary syndrome is not missed. If we cannot do an ECG in some setup, transfer to the emergency department should be initiated as soon as possible. The important advantages provided by the emergency medical staff, it includes acquisition of a pre-hospital ECG, which can facilitate the reperfusion if ST elevation is present. Presence of trained personnel who can provide treatment for chest pain, arrhythmia and implement defibrillation in route, and shorter travel time to the emergency department. So we need that emergency medical personnel to, in case of transferring the patient to emergency department. As per the early recognition of ST elevation MI, it can improve outcome. So an ECG should be obtained and interpreted within 10 minutes of arrival. Immediate transfer to the emergency department is also recommended. Cardiac troponin is the most sensitive test for diagnosing acute myocardial injury, and in conjunction with other essential clinical data like history, clinical examination and ECG, its measurement is necessary to implement appropriate therapy. Delayed transfer to the hospital for determination of cardiac troponin or any other diagnostic testing beyond ECG can be detrimental and it should be avoided.
This is important when people from ED is not there. This is, we often hear we haven't sent tropi because chest pain is less than 3 hours duration. So at the first medical contact, one has to send troponins. Doesn't matter whether the chest pain is for 10 minutes or 10 hours and 1 hour. Good.
This figure shows the different ST changes in case of ST elevation MI as well as non-ST elevation MI, and the lower picture shows the ECG changes in acute pericarditis.
So why ST elevation occurs? What is the basic electrophysiologic mechanism behind ST elevation?
Myocardial injury as well as the disbalanced myocardial oxygen demand supply ratio disbalance is there.
No, but why ST elevation?
Ventricular depolarization. So where is the damage? So in the non-standing, where is the damage in standing?
So mostly ventricular persistent depolarization phase.
So first of all, you have to have a good idea of the different vectors. Okay. So vector cardiogram is a very good way to represent the scalar ECG. Not going into the details, but basically what we need to understand is the ST vector. So the ST vector usually points away from the usually points towards the current of injury. Okay, the current of injury is due to the ischemic process, due to the calcium malhandling or whatsoever is generated, and this current of injury, the ST vector will point towards the direction of the cardiac injury. So if it's a transmural infarct, actually it becomes an electrical window. It becomes an electrical window, and you can see the opposite wall's electrical activity on the lead facing the infarct wall. You understand? So if it is an anterior wall, the ST ST elevation of the anterior leads is basically due to the electrical window that has happened on the anterior wall, and the posterior wall vectors are being ST vectors are being seen. You understand? So this is the possible explanation of ST elevation.
How do you explain it in pericarditis?
Pericarditis also, it's basically the epicardium that gets involved along with the pericardium. So there is always a concomitant epicardial injury. So epicardial myocardial injury along with the pericardium.
You don't get a transmural pathology.
No, transmural pathology is not there, but even then, the epicardial involvement itself, myocardial injury, the ST vector will point towards the lead which is facing the myocardial injury. The concept of electrical window due to the transmural involvement is another possible explanation.
I mean, simply speaking, that is not being able. Because the epicardial injury is the elevation. So in a transmural infarct or still you see that, and that's why you get it. Pericarditis also you have epicardial damage, so you see elevation. Subendocardial, there you see it's a non-steady.
But how do you distinguish what sir was telling? Pericarditis is an acute MI, STEMI?
So, depending on the ECG changes, I can distinguish. In case of, as it is shown in the picture, the different stages of acute pericarditis can have the different ECG findings. In case of,
but the patient is in cross-section, so you don't have different stages to assess.
From the
you will have one single ECG to decide.
So in case of ST segment elevation MI, the concavity of the ST segment is convex upwards. In case of the acute pericarditis, the generalized ST segment elevation.
So that is important. So it is not the concavity also, because like we discussed in epicardial myocardial injury also you will get the same findings as in my situation. But point is, it's a global ST elevation because of the entire epicardial myocardium getting involved, whereas it will be in the distribution of a single coronary artery in the setting of STEMI with reciprocal changes, very important, with reciprocal ST changes in the other veins. For example, if you are having an inferior infarct, 2-3 AVF, so you doubt your inferior infarct unless you have an ST depression in AVL. So AVL ST depression is reciprocal to lead 3 ST elevation. Okay, so these points should be kept in mind.
So in case of acute myocardial infarction, depending on the wall which where there is ischemia, we will be getting ST elevation in those walls. Reciprocal the STT changes, it opposite wall will be found.
Arectal mechanism basically of ST elevation and the hyperactive T-wave changes is due to a localized hyperkalemia in that particular region, because we know that once these cells are damaged, they become partially depolarized and there is ingress of potassium out. So a localized hyperkalemia environment will give rise to the same ECG changes in that particular distribution, just as the hyperkalemic changes you get on the frontal 12-lead ECG in the usual scenario, but in a localized fashion. So these are the 3 explanations. One is the electrical window, one is the epicardial muscle injury, and another is the localized hyperkalemia, accounting for your ST elevation and the hyperactive T-wave changes. Because the ST elevation differential diagnosis, hyperkalemia will always come as a differential diagnosis, dialyzable conundrum injury.
Proceed.
So when
And another thing just to address is the Q wave, because most of us have a notion that once there is a Q wave, even if there is ST elevation, so no reperfusion will be helpful. That is wrong. Within 6 hours, this Q wave can disappear. Once you reperfuse these patients, it is an electrical phenomenon. But beyond 6 hours, the Q waves usually indicate a more severe pathologic extensive necrosis. Okay, but within 6 hours, even if Q waves appear and you have ST elevation, you go by the criteria of ST elevation for reperfusion, not by the Q waves.
should we proceed?
Yeah.
So when a patient with chest pain comes to our setup, the initial evaluation of different diagnostic testing, it includes that when a patient presents with chest pain, we would be evaluating the patient as per history and physical examination, and the primary investigation is ECG. Depending upon the ECG findings, we can follow the different guidelines as per the ECG finding and the diagnosis is concerned. So in ECG, if we find the ST elevation MI, so we will be following the ST elevation MI guidelines, which I
So criteria for ST elevation? How much ST elevation?
so
What lead?
So more than 2 millimeter.
Have you read it or? Just guessing.
No, you are close. It's not more than 2 millimeter, it is more than 1 millimeter ST elevation in all leads except in the right precordial leads, V1 and V2 in case of.
It's different in a precordial and a leads.
Absolutely. In case of.
So right ventricular.
No, in case of adult young males, it is 2 millimeter or more. Okay, that is the exception because early recollection abnormality can be seen in these leads with similar ST elevation. So, two contiguous leads, it has to be there, more than 1 millimeter ST elevation, except the right precordial leads in V1 and V2, where you need to have a more your sort of ST elevation, so 2 millimeter or more, so as to not misdiagnose early recollection as an ST elevation. With obviously
LU and two contiguous leads. These are two important terms.
And another thing that what sir was telling the people is a new onset LVB. That is also a STEMI equivalent. New or presumed new onset LVB is also a STEMI equivalent.
As for the different ECG findings are concerned, if we get diffuse ST elevation that is consistent with pericarditis, then the management would be according to the pericarditis. If there is ST depression with new T wave inversion, that is diagnostic of non-ST elevation MI. There are different guidelines which I am explaining later on. If there is new arrhythmia, then we will be following the arrhythmia specific guidelines. If there is non-diagnostic or normal ECG, we can repeat the ECG if the symptoms are suggestive of any, the symptoms persist or change or it becomes severe with time, or the cardiac biomarkers, like most importantly the high sensitive cardiac troponin, it becomes positive, then we will be repeating the ECG. And also the normal ECG may be associated with the posterior wall involvement. So the right-sided ECG leads should be also considered when the such lesions are suspected. Right ventricular ECG we should be doing if the posterior wall MI are also suspected. Also the different other investigations in the first initial evaluation setup, it includes chest radiographs on presentation, but this should not delay urgent revascularization if it is indicated. Preferred biomarker to detect or exclude cardiac injury is cardiac troponin, high sensitive cardiac troponin, that is either I or T, because of its high sensitivity and specificity for myocardial tissue. Detection of myocardial cell injury, possibly indicative of AMI, is predicted on a rise or fall of this biomarker in the.
One thing just I wanted to note, because this can come in your exam, in your short note also. Two entities you should remember. One is Whelan syndrome and one is De Winter's syndrome or De Winter's sign. Because even if they are classified as non-STEMI, these patients are equally bad prognosis, similar to STEMI patients. So you should be well aware of the entity called Whelan syndrome, and another is De Winter's sign. So Whelan syndrome is there where you get a biphasic T wave response. You can search in your mobile also, Whelan syndrome images. So ECG images, you will get it. So a biphasic mid-precordial, V2, V3, V4, either a biphasic T wave response, initial positive and then negative, or it is a symmetric deep T inversion in V2, V3 and V4, type A and type B. The first one is type A and second one is type B. That actually is an aborted anterior wall. And unless these patients need urgent reperfusion, and unless you address these patients interventionally, even in the best of medical management, 50% of these patients will have acute anterior wall MI within the next 7 days. And De Winter's sign is basically a sign where you get an initial ST depression, slight ST depression, and then a hyperactive T wave response forms entity. And this entity you should recognize, because this entity, unless you recognize, the next day you can get a Q wave in the same ECG leads. So, and this is due to the same explanation of the localized hyperkalemia, the hyperactive T wave changes, that you should recognize. Okay, and treat them urgently, intervention.
This diagram shows the different cardiac biomarkers depending upon the on the x-axis. There are days after onset of acute myocardial infarction, and the levels of the cardiac biomarkers as they rise and fall over the period of time. This is shown in this diagram. The most important cardiac biomarker is cardiac troponin, that is shown in the red line. It is raised in the initial days on the first day. Most importantly, within the first day it rises, and it reaches the 99th percentile. It reaches within 6, and after 5 to 6 days it reaches the 99th percentile. Other cardiac biomarkers that are included in this slide are myoglobin and CK and CKMB. So, as per the different investigations,
do you recommend the CPK-MB? Just go back to the slide.
So, for the initial evaluation and diagnosis, only the high sensitive cardiac troponin is.
The question is, do you recommend CPK-MB testing or not? For diagnosis?
Recommendations are inconclusive.
Recommendation is class 3 recommendation. You should not do it.
Which one?
CPK-MB.
So these are out of vogue now. CPK-MB,
We are talking about 2021. It's a class 3 recommendation, because we still see from various nursing homes getting CPMBs.
You should not prescribe.
So this is all the way problems.
But sir, is there any role of CPK or CPK-MB when you consider the diagnosis of re-injury or
No.
repeat?
Even for injury, even for injury,
The kind of
re-injury, it's a reinfarction.
you should wait to this new universal definition. Initially, cutoff for re-injury was 50 times. Say you are subjecting patient to PCI or CABG, there will be rise. So the cutoff for post PCI trichloroamide is 50 times.
50 no, 5 times.
No, but CABG is 100 times. So this range is increasing. So initial concept was, if you are suspecting second MI, then go for CPK-MB, because fall is much quicker than the troponin I. You said troponin I will plateau after 2 weeks. So if you want to know in between, then probably CPK-MB. But nowadays that has also been strict. Threshold has been raised for troponins. So 5 times, 10 times, now it is 50 times. So in nutshell, CPK-MB is obsolete.
Now, what they have told in this universal definition, the definition of reinfarction, it is within 28 days of the index MI. The definition is within 28 days of the index MI. Before that, you cannot call a separate infarct. So it is a reinfarction. This is one thing. And the second is, again, it's your symptoms of ischemia, ECG changes or whatsoever, any one of the accompaniments, plus a rise of more than 20%. Rise of more than 20% from the baseline, okay, and an absolute value of more than 5 times if the patient has undergone a PCI or CABG. So this is the definition of reinfarction. So CPMB is out of vogue.
So the acute chest pain evaluation, and with the patients having major risk of cardiovascular accidents or events, the high risk patients also, as per the anatomical functional testing also included, the high risk patients and the patients more prone to develop any acute coronary syndrome, they should undergo, if indicated, invasive coronary angiography. This pyramid shows the different risk factors of the patients accordingly, from asymptomatic to the high risk and ACS prone patients. the different testings we should do in cases of as per the risk of the patient is concerned.
So intermediate risk and above, most of these patients at some point of time will need a coronary angiogram. Only in the low risk patients where you have serial biomarkers related, no wall motion abnormalities or this chest pain by definition didn't meet a criteria suggestive of an ischemic etiology, etc. Those patients you can triage by your non-invasive testing. So this is as per the guidelines. Okay. So intermediate risk or high risk, obviously these patients need an urgent coronary angiogram, but intermediate risk also maybe within a day or two, these patients will require an angiogram.
This is patient-centric algorithm for acute chest pain. As per the patient's if a patient presents with chest pain, firstly we should evaluate if the pain is acute or not. If the patient's pain is acute, then we should follow the algorithm as the algorithm is written over here. If the pain is acute, we should be evaluating the patient according to the history and physical examination, as well as we will be doing an ECG, as I have already explained. If the ECG shows if there is any potential cardiac causes, if it is STEMI or not, ST elevation MI or not, we should be diagnosing it at first. If it is suggestive of ST elevation MI, then we should follow the ST elevation MI guidelines. But if the ECG, that is potentially cardiac cause is there, but it is not ST elevation MI, then the evaluation should be based on suspected etiology using patient-centric algorithm. That can be of different types. The potentially hazardous cardiac cause, but it is not ST elevation MI. It can be different things. Like acute coronary syndrome, that doesn't include ST elevation MI. Other acute coronary syndrome causes. It can be acute aortic syndrome. It can be pulmonary embolism, acute myopericarditis, or valvular heart disease. So we should be evaluating these causes as per the different patient profiles to have the next line of treatment as per our protocol. This is the general approach of risk stratification of patients with suspected acute coronary syndrome. This is similar to that other last slide, that is patient-centric algorithm. Here we stratify the risk of the patients and we classify them into 3 groups: low risk groups, intermediate risk groups, and high risk group. As per the pyramid diagram is concerned, the low risk group we can opt for no further testing and we can discharge the patient according to
So what do you understand by high risk and what do you understand by intermediate risk?
Sir,
high risk category.
So other comorbidity factors and the patients more prone to develop acute coronary syndrome.
High risk is certain criteria. Key.
So prior
high risk হচ্ছে hemodynamic stability, life threatening arrhythmias চলছে, ঠিক আছে, acute ongoing ischemic chest pain. So এগুলো সব পড়বে হচ্ছে তোমার heart failure বা তোমার hypotension, life threatening ventricular arrhythmias, or patient having acute ischemic chest pain. They cannot wait for anything. So you have to go for an urgent reperfusion strategy or urgent triaging and stabilization of the patient, whatsoever means. Intermediate risk, which is a high risk features will name. The high risk features are not there.
These are all for non-ST elevation. Be very clear. STEMI is a separate pathway. STEMI pathway, basically you find STEMI, you reperfuse. So chest pain, ECG showing ST depression or normal, near normal ECG, then how will you try whether this is high risk,
intermediate risk or low risk. Okay, so intermediate risk is absence of the high risk features, plus either these patients are aged, say more than 65 years, having diabetes or whatsoever comorbidities were being mentioned, had a prior MI or a revascularization done, or these patients have prior LV dysfunction. So these, or patient had rest angina within the last 48 hours. So they become intermediate risk, any one of them. And absence of all of them will put this patient into a low risk category.
Sir, in this risk stratification, can you use the Lee's revised risk cardiac index?
No. One is if you have a troponins or if you don't have troponins. Troponins usually take time, 45 minutes, not before that. So before you get troponin, just look at the electrical stability, hemodynamic stability. If he is electrically stable, no arrhythmia, nothing, BP is normal. So then learn some sort of a scoring system. Either you can learn a GRACE score, which requires a mobile. You can go for a TV score. Different countries have different scoring systems.
So whatever you adapt,
get used to one scoring system. So that will lead you somewhere.
So
because once your troponins come,
then it changes.
Muscle changes straight away.
So troponin is positive.
Once troponin is normal, we need to unstable angina or non-cardiac, either of the two. And accordingly, you take a call, either you will subject him to a stress testing or stress echo, whatever. So clinical decision pathway involves two things. You have to get tuned to at least one risk scoring system, and of course troponins, as well as electrical and hemodynamic system.
Changes what has been described or been described by you, ST depression or new T-wave inversion. So if ST depression is there and dynamicity is there, again this patient is going to high risk criteria, and T inversion only, but not more than 5 millimeter, comes into the intermediate risk criteria. So electrical criteria what has been discussed, and troponin positive high risk criteria.
Do you have a next slide based on troponin? Rule out MI or something like that?
I have the different algorithms of the patients we will be discussing with known cardiovascular disease.
No, for MI, can we rule out MI in the emergency department? You have to send the patient either home or you have to admit him. So, do you have any slide here? No. There are various, like, usually this is based on troponins. So, you can rule out with ECG and 0 hour and 1 to 3 hours troponin. And majority of the cases, if your 0 hour and 1 or 3 hour ECG, depending on the institution, are normal. If there is no delta in troponins, that means rise is less than 5, and you can safely send them home. If ECG is abnormal, fine, he is in. If ECG is abnormal, troponin high, he is in. If delta is there, initial troponin was normal and delta is going up more than 5, you have me.
So when you say more than 5,
Yeah.
you mean
The difference between the baseline troponins and next troponins. Say it was 0.01 and if you have a rise of more than 3.5% negative. So there has to be a delta of at least 10% to diagnose MI if initial or normal. So rise and fall is pretty important and it has to be 10%. In our scenario, we don't have it because our troponin will take 45 minutes, forget about the second. So you have to rely on the hemodynamic electrical instability, ECG changes, you admit.
So in
Now
our
that is easy.
chest pain triage and requires an admission and observation over 6 hours at least to have your ECGs serially
And
have
at
your
least
troponins,
2 troponins.
and echo if possible or if
sorry, I still did not get it. Is it time or time per second?
Which rise and fall is 10%.
10%.
10%. Less than 5% you can send it. Delta is no problem. Proceed.
The warranty period of prior cardiac testing, as per the medicine guidelines, suggests if the patient had normal and coronary angiogram with no stenosis or plaque within last 2 years, this anatomic testing can be required as and as per the stress testing, if given adequate stress and the patient has achieved normal stress test within last 1 year, then this stress testing to risk stratify the patient is not important.
So is there any role of CT coronary angiogram in the emergency setting for chest pain evaluation? What we are describing is basically patient's prognosis.
Yes.
Once a normal CCTG comes, the prognosis.
This slide tells. This slide shows CT.
So proceed.
Yeah.
There is an evaluation algorithm for patients with suspected ACS at intermediate risk with no known cardiovascular disease, coronary and arterial disease. If there is prior testing is done or not, we will be first assessing that. If there is any prior testing done and the recent test is negative, then we will be discharging the patient. If the prior testing is inconclusive or maybe there is mildly abnormal stress test, then we will be proceeding for angio. And if there is prior moderate or severely abnormal stress test or interval coronary angio,
prior inconclusive.
যদি prior মানে mildly abnormal বা inconclusive testing করা থাকে within 1 year stress testing, তাহলে we will be proceeding for coronary computed.
কেন?
Acute chest pain is you don't want to send him home because he has a borderline, say, treadmill done 6 months back. Now he has come with the chest pain, ECG, some changes showing. You can't really send him, so it's fine. That is why yellow means class 2A.
No, but even then, it's a CCTA. If you are doing a calcium, you get a calcium score 0. There also, there is a 10 to 15% chance that these patients can have lipid-rich plaques without any calcium and have a plaque rupture leading to your acute coronary syndrome. So you may miss cases.
Yeah, that is why the prior inconclusive means he had the initial, let's say, CAT score of 190. Then he is into that category. So intermediate means based on age, gender, treadmill, CAT score, so many things. Yeah.
So the prior testing was previously done and the recent negative test we will be discharging the patient. If there is inconclusive or mildly abnormal stress test within last 1 year, we should be proceeding with angio. Then the angio can differentiate the obstruction patterns or obstruction degree of the disease. If there is non-obstructive type of CAD finding in angio, we can discharge the patient.
Means less than 50%.
Less than 50%. If it is
there is an entity called myocardial, you know? So MI due to the non-obstructive coronary disease. So if your patient has MI, whatsoever cause, then the patient gets the tragic and your treatment as per MI. So you don't discharge.
This is for suspected ACS, but troponins are not high.
But troponins are not elevated. This is important.
If the coronary angio gives inconclusive report about the stenosis degree, we can assess the patient with stress testing, and if the stress testing or if positive or not, we can further manage the patient according to the guideline directed medical therapy. Guideline directed medical therapy can suggest whether the patient to be discharged or not. And if the obstruction of the patient is more than 50% stenosis, then we can also go for the guideline directed medical therapy and plan for discharge accordingly. Then the next group is there is no prior testing done when the patient presents to the emergency department with acute chest pain at intermediate risk, but no prior testing was done. Then we can do two different type of testing. Like firstly, we can do stress testing, like exercise ECG or stress CMR or stress PET, and we can find the degree of ischemia depending upon the 3 different groups we can do. Right? If there is a negative stress test, then we can discharge the patient. If there is moderate to severe ischemia, then we can proceed to the last part is we can proceed to invasive coronary angiogram. And if there is inconclusive test, then we can also proceed to coronary angiogram.
So what will you do? Your hospital has both the things. You have a CCTA and you have a stress testing. So which test do you opt for?
So if stress testing can be done at first, so I can prefer that also.
Our answer is this is a shared decision. You discuss with your patient and look at his preference, give what are the advantages. So you have to answer in that way. It's not only physicians' call, so it is a shared decision making, discussion with the patient. Because all the tests are available in most of the hospitals.
No, there are what sir was saying, but there are additional pros and cons. So, for example, if you have a low risk patient, preferable is a stress test. Why? Because stress test is a physiological one. So you can assess patient's exercise capacity, you can assess his heart rate response, his autonomic balance, and many other parameters for his long-term cardiovascular prognosis. Apart from, he gets a confidence of the amount of activity he can do post-discharge. Okay, apart from assessing the ischemia. Ischemia is only one part. Okay, and coronary angiogram through CT also entails radiation and contrast. So, if you want to avoid radiation contrast and patient is a low risk patient, stress testing, if the stress test is inconclusive or positive, then you can try these patients for your more hazardous tests.
And in the stress testing, you have mentioned so many things. So, which of the stress testing you will opt for? Exercise or stress echo, or I just asking you, which of the stress testing you will advise?
Exercise ECG or exercise ECG.
So that 100 kg lady with osteoarthritis, she cannot walk, or she has got left ventricular hypertrophy on the ECG.
So,
ECG will go for stress ECG.
So, if the patient is ambulant, has a regular.
The point of asking is you have to know where you will advise exercise ECG, where you will advise stress echo, where you will ask for stress CMR, go and study. Whether the patient can exercise, whether the ECG is interpretable or not. So these things will decide. But you have to answer in a very certain way. Okay. Postgraduate is different ballgame. It's not MBBS.
And similar algorithm is also suggested as the previously it was said. When the patient is going for cardiac computed angiography, then there are different obstruction parameters we will be assessing. If there is less than 50% stenosis, we can discharge the patient. If there is inconclusive stenosis or more than 50% stenosis, then there should be guideline directed medical therapy. And we will be planning the patient whether he should undergo invasive coronary angio or we can discharge the patient according to the findings of guideline directed medical therapy.
What is the full form of FFR? Because you are purposefully omitting, you are mentioning GDLP guideline mandatory. Examiner will pick up these things. So you have expanded GDLP but never pronounced FFR. Fractional flow reserve. So the motto is whatever you project, you must know. Otherwise, this is a basic examination. If you utter a word, you should know in depth. Fractional flow result can be done in CT to find out the physiological significance of the blockage. So next slide is if it is less than 0.8, it is significant. Go ahead. These are for postdoctoral.
This algorithm shows the patients with suspected ACS at intermediate risk with known CAD. This can be firstly this can be classified according to the obstruction. If there is less than 50% stenosis, it is classified as non-obstructive CAD. We can go for coronary angio or stress testing. As well as if it is obstructive CAD, then we will be going for coronary stress testing first. angio, when we will be doing it, it can show either no change or there may be showing obstructive CAD with more than 50% stenosis. If the coronary angio is showing no change, we can discharge the patient, but as considering the next management line of management, INOCA pathway. If there is obstructive CAD in the coronary angio, done in case of non-obstructive CAD suspected patients, as we have done the coronary angio, then we can go for stress testing or FFRCT. FFRCT, if the finding is persistent for guideline directed medical therapy, then we can discharge the patient, or we can shift it to the obstructive CAD algorithm. This obstructive CAD algorithm, if the patient is undergoing stress testing of different kind, like stress CMR, stress echo, stress PET, or stress PET scan, the normal finding in stress testing, we will be discharging the patient. And if it is abnormal, then we can defer the patient with multidisciplinary clinical decision making pathways should be there, or invasive coronary angiography, we should be preferring that in case of if there is abnormal stress testing.
For the rest of the house, the meaning of FFR is basically fractional flow reserve, that is a ratio of the present flow in the stenosed artery to the flow in the artery if it was not stenosed in the maximal hyperemic state. So, normal artery fully dilated, the flow you calculate, and the present flow you calculate. So, the ratio of the present flow, which will always be less than the maximal dilated artery flow of that particular segment, the ratio is calculated and that is expressed as fractional flow reserve. And the fractional flow reserve of 0.8 or less is significant. Means there is a significant obstruction to flow. Of anything more than 0.8 is non-significant. That means there is no significant obstruction to flow. So therapeutic decisions are based on this magic number of between say 0.75 to 0.8.
So we have these two new terminologies. One is INOCA and another is MINOCA. Ischemia with non-obstructive coronary arteries, and another is myocardial infarction with non-obstructive. So INOCA and MINOCA are good short words. Good to say.
There are different recommendations of acute chest pain with prior CABG surgery. In patients with prior CABG surgery presenting with acute chest pain who do not have acute coronary syndrome, performing stress imaging is effective to evaluate for myocardial ischemia or coronary angio for graft stenosis or occlusion. Another class 1 recommendation is if they do not have ACS or have indeterminate or non-diagnostic stress test, invasive coronary angio is useful, as I have already discussed in the previous slide. Sir, evaluation of chest pain with patients receiving dialysis when transferred by the emergency medical personnel. Next, which is cocaine and methamphetamine use in case of patient. We should be considering the cocaine and methamphetamine use as a cause of their symptoms. Recommendation
Shared decision.
Shared decision.
Next,